we're about time. So again, just a welcome and thank you for joining us on this exciting webinar today on leveraging best practices in social accountability to improve RMNCAH service delivery. My name's Andrew Brown from MTaPS. I'm going to be your facilitator, and we're going to be together today for a couple of hours. But to start us off, we're very excited to have Alexis Leonard, the COR for the MTaPS project. And we'd like to invite her to give us a few opening remarks to set the scene before we dive in with our subject matter experts. Alexis, over to you.
Thanks so much, Andrew. So hello and welcome. First of all, thank you to the MTaPS program and Momentum Knowledge Accelerator for jointly organizing this knowledge sharing session. And thanks to all the participants for taking the time out of your busy day to join us for what should be an interesting session and discussion on using social accountability to improve access to MNCH medical products. As many of you know, MTaPS is a USAID-funded project that aims to enable low and middle-income countries to strengthen their pharmaceutical systems for improved health outcomes. One of the many areas of support the program provides is around good governance of pharmaceutical systems, which requires transparency and accountability. Social accountability is important for pharmaceutical system strengthening because when communities hold authorities accountable for health service delivery, it can lead to improvements in the quality of health and pharmaceutical services. This is particularly important in pharmaceutical systems, which consists of a complex network that spans from procurement to health products to distribution to the point of dispensing to clients, which provides many touch points where society has the opportunity to demand quality services and have their needs met. And when we promote transparency and accountability, we can help improve equitable access to essential medicines and other medical products that are safe, effective, and of high quality. Absent or poor accountability in a health system directly affects the ability to implement quality health services, and this is especially important as we try to reduce the large gaps in maternal and child mortality. Civil society has an important role in the governance of our health systems, and while government bodies can hold authorities accountable, it is the citizens, ordinary people, who are ultimately impacted by healthcare decisions and the ones that must take collective action to influence and demand accountability and quality services. I hope you find these lessons generated by MTaPS and Momentum Knowledge Accelerator and the discussions useful and are able to find ways to apply them to your specific situations to improve pharmaceutical systems and health outcomes in your country. Thank you so much, and we look forward to today's session.
Thank you so much, Alexis, for setting the scene for us. Lauren, would you like to just tell us a bit about the technology we're using today?
Sure, Andrew, thanks so much. And thanks, Alexis, for that welcome. Just some quick housekeeping as we get ready to kick off what is hopefully going to be an exciting session for everyone. The first is we kindly ask everyone to keep their microphone muted during the presentation so that we can hear all the speakers well, and also keep your camera off during the presentation. In terms of questions and comments, if you have any, please add them to the chat box. We have a pretty full session, so we'll try to take some verbally with the speakers, but our speakers will also be engaging with you in the chat box and responding to your questions and comments there. And final note is that we are recording this session, and it will be made available as a resource following the session. Thanks, and back to you, Andrew.
Thanks, Lauren. If you could skip forward a couple of slides. This is a joint event today, and we're so excited. It's being hosted by MTaPS and Momentum Knowledge Accelerator, known as MKA, the Connector Award for the Momentum Suite. We've got a range of speakers today from USAID, as well as several USAID-funded projects, namely HERD, Breakthrough Action, and 3 of the 6 centrally managed Momentum Awards: Momentum Country and Global Leadership, Momentum Integrated Health Resilience, and Momentum Knowledge Accelerator. An exciting group of people that have come together around this topic of social accountability and how it interacts with improving best practice for service delivery. It's a 3-hour session, so I'd like to give you a quick overview of how we're going to do that. We are going to start off with a presentation from our subject matter expert consultant, Walter Flores. He's going to set the scene. What prompted this particular webinar was some work we did within MTaPS, looking at what is the really best practice approaches when we're going to engage civil society for the purpose of improving the availability of RMNCH Medicines. And Walter is going to present to us the findings of that. Then we're going to move into a panel where we're going to have some reflections from different projects about what they're doing in social accountability, with social accountability in their projects, but what reflections they have on these particular best practice steps that we have discovered through some background work. We're then going to move on to a range of flash presentations that will give us insights into different projects that are using social accountability, but also then looking a little bit more deeply at some of the contrasting and comparable accountability frameworks. So hang on to your seats. We're looking forward to great interaction from you in the chat. So as we move along, if there are particular messages that you would like to give us, if there are questions you'd like to ask, please do so. And then right now, I'd like you to take your cursor to the bottom and find the reactions. And as you go along, feel free to give us some reactions as well. Next slide, please. Without further ado, I'd like to introduce to you Walter Flores. He's an MTaPS consultant, and he has been doing some work with us in this area of social accountability. And Walter, I'd like to hand the floor to you to give us an overview of the particular steps that we need to be thinking of and best practices in this space. Thanks, Walter.
Great, thank you. Can I have the next slide, please? So in my brief presentation, I first am going to summarize some key concepts, then the lesson learned that we gathered from reviewing the literature. After that, I'm going to summarize our proposal to improve the way that we approach civil society engagement and what exactly means. And I'm going to finalize with some key action steps. Next slide, please. So 3 key concepts, which are very important. The first one on civil society. What is important here is that a civil society is really a broad category of actors and includes grassroots organizations, but also includes organizations that are for profit. And it may include academia as well, but very importantly is that this very broad sector of actors, not all of them share the same goals and visions. Just because they are civil society doesn't mean that all of them are aligned in the same goals. In fact, in many cases, they are actually opposing each other in terms of the goals. So when we are talking about civil society, we are really talking about those actors which share our views and goals. But really, we have to be aware every time that civil society includes all this variety of actors that I said. And within the report, when we refer to civil society, in some instances, we're referring to those ones that are aligned to the goals of improved health for marginalized populations. In some other cases, we are referring to this scenario that is very contested among different actors trying to influence public policy and public budgets and resource allocation, okay? The next concept, which is very important, especially for social accountability, is grassroots organizations. Usually they are referred as part of civil society, but for social accountability, it is very important that we make the difference that grassroots organizations are those voluntary community-based organizations that their goal is to improve the living conditions and services of the territories where they live. In other words, they are not professional people that are paid to work in development. They are voluntary people. And this is very important for social accountability. And there are many concepts of social accountability, but what we need to keep in mind is that first, it's a participatory process of those directly affected by the problems in which they engage to try to influence public policy and services. So this is very important because if we are working in our projects and intervention with a civil society organization, a think tank in a country that's very specialized in procurement, is very specialized in in budget tracking, but it's at the national level and it's a specialized NGO, that doesn't make it a social accountability by itself. We can say that we are working with civil society organizations, but it's not really social accountability. Social accountability must have the direct participation of people directly affected by the problems. And also, we need to make it clear that although social accountability includes technical processes such as collecting data for monitoring, also the heart of social accountability is this process in which directly affected community organize, build alliances with other actors in civil society. For instance, alliances with these specialized NGOs at the central level, and they engage at different levels to trying to influence government policies and services. Okay, so that is very important to keep in mind from the social accountability concept. Next one, please. Okay, from the literature, which we review a lot of recent articles, and what we identify is three main lessons from almost 2 decades of implementing social accountability. The first one is that to implement an effective social accountability, we need to have channels of engagement. We need to have spaces for dialogue between the different stakeholders, in this case, directly affected community, frontline service providers, health authorities, specialized NGO, and many other actors. So enabling conditions through the facilitation of these spaces of dialogue so they can have coalitions as well is very important. And here we are talking again, not only about the same actors that we usually reach through our project, but actors that usually outside of the traditional stakeholders. For instance, human rights activists, journalists, especially the journalists that are interested on investigative journalism are very important. And ombudsman roles, for instance, are very important. The next important lesson is that we just start, in many cases, implemented social accountability with the assumption that because these communities are affected by poor services, so many barriers to access, that they are ready to engage in demanding accountability and demanding improvement to services. What we found from the literature is that in many cases, because marginalized populations have also a history of social exclusion, they are not really readily aware about the rights, about their entitlements to quality healthcare services, about their entitlements of specific services that they must receive. So an important component of any social accountability must be a process of rights literacy or a process of educating user of services about the rights, their entitlements, and the importance to access high quality healthcare services. So this is very important because we may need probably several months or probably more than a year to implement these broad campaigns or informing users about the rights and entitlements, okay? And the third main lesson learned that we identify is that even at the most periphery of the services, the problems that is affecting high quality of services or access to the services are related to problems higher up in the system, in the health system. It could be at the regional level, it could be at the national level, but all problems or most problems are related to situations higher up in the system. So it is true that many social accountability interventions are only implemented at the local level. But that doesn't mean that we should only stay at the local level, that the most successful social accountability interventions are the ones that start at the local level, but they manage to build coalitions at different levels of government. So they can actually act on the conditions that are causing the problems that are happening at the local level. So social accountability, again, although it may happen or start at the very local level, one of the goals is to tackle the bottlenecks that are affecting the problems identified at the local level. The next slide, please. So based on those lessons learned, we are proposing three main goals and approaches for to improve. The first one is that we should do the mapping and analysis of the accountability ecosystem. I'm going to explain in a minute what is that. The second one is that social accountability should be strategic. And the third one is that we should aim for vertical integration of social accountability actions. Next one, please. So the accountability ecosystem is the relationship of the multiple levels of governments and multiple levels of stakeholders and actors in any given countries. The accountability ecosystem exists in every single country, including in countries that face a crisis, on countries that are affected by natural disasters or other conditions. There is an accountability ecosystem. The difference mainly is going to be that the level of formal procedures in those countries, as opposed to more of non-formal procedures to organize the decision-making, to organize and implement governance arrangements, and to decide about key decisions in the country, which include the allocation of public funding. And basically, there are three main components of this accountability ecosystem. As I say, is the formal procedures, the laws that we can see, the norms, the regulation, everything that is explicit or in written forms that we can review or anyone can review, but also includes all those non-formal procedures that are not very easy to grasp, that we need to engage in that context to understand what are those non-formal procedures. They are very important because, as I said earlier, in some contexts, there are a higher presence of non-formal procedures for decision-making about public services and allocation of public budgets. Also, it is very important that this accountability ecosystem, it will give the possibilities to any social accountability to become effective, but also to be sustainable and to be able to engage with the bottlenecks at different levels of government. And a social accountability intervention that understand this context and try to engage with the ecosystem have a higher chance of impact. Next slide, please. So as you can see on the report, this is just a generic representation, just to give the idea that if we are working in the health system, specifically on medical products, we, in addition to our traditional stakeholders or actors that we engage, there is an important role for the courts, the court system, for parliament or Congress, also an important role for Ministry of Commerce, Ministry of Finance, even the Ombudsman Office. Those countries that have the Ombudsman Office of the Human Rights Defender role, they play a very important role as well. And in addition to this formal process, we have the social norms in the countries, we have the belief system in the countries, and we have the traditional mass media, but also social media. And in this generic example that you could see, some organizations have a very solid line, which means there is a hierarchy on decision-making, and some other have dotted line, which means that the role to influence those organizations is not based on formal hierarchies, but more based on different processes of advocacy. And as you can see also in this representation, health cooperation agencies are apart from this, and are apart from this because really we as cooperation agents do not have that level of influence into this process. We need to understand it and work with different actors, but it's not a solid line because that level of hierarchy of decision making, it is not there. Okay, next slide, please. And with strategic social accountability, this is very relevant because for many years, social accountability was understood as identifying one single tool or one specific tool, and then you implement that tool, and that would improve all the services for the community. The evidence that we have for more than 2 decades is that, as I said before, social accountability are implemented in this context with many stakeholders with different interests, and one single tool may not be sufficient to influence the decisions. Also, the idea that just to provide information is sufficient for citizens to act, the evidence says no, it's not sufficient. Citizens or users of services need more than just the information to act. And thirdly, that most projects of social accountability were 1, 2, or 3 years projects that it was assumed that this was a sufficient period to see changes in terms of the actors being empowered to demand quality healthcare services. The evidence tells us that those successful experience of social accountability takes longer, some of them 5 years, to see these changes in terms of empowerment, but also among the different stakeholders, okay? And finally, what is very important also to have in mind is that, as I say earlier, although social accountability may start or may have an emphasis on local context, because that's where most marginalized people reside, that doesn't mean that we should only work at that context. We need to work at different levels. So strategic social accountability aims to do an integration at different levels where decision-making are made in terms of service delivery, allocation of resources, and public budgets. And the final comment is that social accountability interventions, because they are implemented in contexts that are very complex, they are not a straight line. There is not something that we know exactly from the beginning what is going to happen. It's a very contested process on the intervention, and there is uneven process. Sometimes we think that we are moving ahead, then we are going backward, etc. It's a very iterative process, okay? Next one, please. And with the vertical integration of social accountability, let me clarify that vertical integration has a very clear meaning within health system, which is the integration of healthcare and protocol among the different service delivery institutions or service delivery establishment. But this concept within social accountability does not come from health system, it comes from political sciences. And it basically means the integration of strategies and actions for advocacy at different levels of governance. So it's very similar, the idea about integration of healthcare, but again, within the political sciences, does not mean specifically healthcare, it meaning strategies and actions for advocacy that should be integrated at the local, municipal, regional, provincial, and national level. And very importantly, this concept was first applied in the agricultural sector, then in the education sectors, and now we are applying it into the healthcare sector. And again, it means that we have to integrate the strategies. That doesn't mean to do exactly the same action at different levels. It means that if at one level we are collecting data on health posts, at the next level, which is the provincial level or the district, we should bring all the data together and try to present a picture of what's happening to all the facilities in this region, okay? So the advocacy is not based on individual health posts, but the advocacy is based on what is the picture for the entire geographical region that we can tell authorities that needs to be improved. And similar when we move to the regional and national level, okay? The idea of vertical integration is to build the linkages that is going to allow us to implement effective advocacy and aiming for systemic change. The next one, please. And this table is just some examples of entry points, and I just want to make emphasis in a few of them. We know that in many countries, we have done a technical capacity building to providers. We have worked to implement protocols, implementation guidance for services, and we also have supported, or some other funders have supported, the improvement of healthcare facilities. But in some countries, we see that despite all this improvement, still there are some barriers in place, or still users are not reaching the services. So in this context, in these situations, it's very clear that it's not mainly or primarily a problem of lack of capacity of provider, or that the services are not well equipped. It's basically that somebody somewhere in the system may not be giving priority to services for marginalized populations, or may be decided not to implement the services that are needed. So in this context is when a lack of trust among different actors may be the main barrier, and social accountability is a great intervention to try to improve the level of trust among the different stakeholders. We are listing here some specific strategies to do that: spaces for dialogue, a scorecard to monitor local performance, information that is user-friendly, and also mechanisms to report the problems. Another example is when the problem of stockouts at the periphery is not because the medicines are not there. It's that many cases the medicines are in the warehouses. But what's happening is that the process to move the medicines from the warehouses to the periphery, it may be not happening, it may be suffering delays, or it may not be given the priority by those in charge of taking those decisions. So that's another example that more technical assistance is not going to solve that bottleneck, because it's basically a authority taking the decision or not to give priority to them, okay? So that's another example when social accountability can also be very effective. The last one, please. And finally, 2 minutes to explain the key action steps that we say. Mapping and analyzing the accountability ecosystem, we want to know who are the actors taking the decisions and who can we align with. Also, as a next step, we want to know that from all the issues that the country is facing, very clear we cannot solve all of them, but we want to identify which ones are feasible to tackle and what is required to tackle those services. The next action step is that based on our mapping accountability ecosystem and the feasibility of interventions, that we design and implement a strategic social accountability, the combination of strategies and tools that will resolve the bottlenecks. And the next step is, again, the combination of action strategies that will occur at least at 2 levels. It doesn't mean that we need to work at all the levels at the same time. We can start with 2 levels in the system and then gradually improve as we build more coalitions. And finally, that we need to expand that coalition of actors. We need to have more and more actors beyond just the healthcare sector, okay? The next one, which I think is the final one. Well, final one, there are more resources here and where you can find the full report. Thank you.
Great, thank you very much for that presentation, Walter. That was very comprehensive and really kicked us off and has set the scene. So my name is Jane Briggs. I am the lead on maternal newborn child health activities at the MTaPS program. And together we've been working on this work that we're very excited about, this opportunity to use some of the work that we have gone through with Walter and Andrew to really kind of stimulate some discussion today. And so I think Walter's done a great job of outlining some of the lessons and the key action steps that we have identified to engage civil society more effectively through social accountability. And I think it's important to stress that this work, it was focused on social accountability to improve access to medicines. But obviously the lessons learned and the proposed actions apply to other areas of healthcare delivery to priority populations, such as women and children, which is why this is applicable to the area of interest today, reproductive, maternal, newborn child, and adolescent health. And so this is why this is the subject of our reflections today. And before we move into the next part of our session, which is a panel to kind of reflect on some of these messages in a little bit more detail with other actors, a couple of minutes on some questions for Walter. There's a question that came through, Walter, that was targeted to you, saying, thanks for a comprehensive presentation. And talking about marginalized groups. So Sarah says, you mentioned that the marginalized groups, for many reasons, are not aware of the rights that they're entitled to. And so they might not be very likely to voice their concerns, which is important. What would be some effective strategies and techniques to get the most marginalized groups involved and build their trust in the health system? Walter, over to you to address that.
Yeah, thanks for the great question. Some of the lessons that we have from the experience of different countries is that usually for issues of trust, the best actors or the best organizations to facilitate that are grassroots organizations, organizations that look very similar to those marginalized and affected populations. Intervention that comes top down from the national level or even authorities telling people they do not work because a problem of trust is a problem of trusting hierarchy and trusting power above. So the most effective strategy, again, means providing support and resources to grassroots organizations so they themselves implement information campaigns, produce materials in their own local languages for communities. So those are the most effective strategies.
Great, thank you for that response, Walter. Another question is around this issue that you raised of building coalitions, and you talked about it when you were talking about the mapping of the accountability ecosystem, the importance of engaging with stakeholders that maybe we don't normally engage with, that are outside of sort of the typical health structure. And so I wondered if you could comment a little bit more on that. Is that something you feel should be relevant to most contexts of social accountability approaches? And maybe you could give us an example or two of how that's been used successfully.
Yes, if we are aiming to tackle the bottlenecks affecting the quality of services at the periphery, which is our concern for most of us, we will have to engage with a broader set of actors because, as I said, in the ecosystem clearly shows that there are many actors involved. And in the report, we have some boxes in which we explain some and describe some successful strategies in which services and through social accountability, there was a coalition with journalists, another one a coalition with the Ombudsman Office, which was very effective. They were very effective to open up channels of engagement at higher levels of government, but also tackling some of the bottlenecks. So if we are aiming to try to make our interventions to have the potential for sustainability, but also to get into the systemic causes, we will have to engage with a broader set of actors. Otherwise, we will not have enough force or enough power to tackle those bottlenecks.
Great, thank you. And so then I think Andrew will permit me to ask one last question before we move on to the next session. We've had a comment here, thank you for the many great insights, and a question on sustaining community engagement. How do we sustain community engagement in social accountability interventions? What brings unpaid people back every week, every month? How can the process be less burdensome, or will they only engage while the issues are problematic, or if they're being remunerated in some way? Could you comment on that for us, please?
Great, another great question. We have already literature showing these experiences in which there is a higher chance of being sustainable when these processes are owned by communities, are owned by grassroots organizations, and it's not perceived as an externally funded top-down projects. When we are able to generate this coalition of affected actors and communities, and they see like this is our own process, and we are getting empowered through this process, those processes sustain. I had been engaged in one process like such for almost 20 years by now. This is still there, still exists. And the key feature of that is that it was always community driven, it was community supported, and the priorities of communities. So the key message here is that we need to have patience for those processes, not to think in short term, but to think that these are engagement that take years, a longer process of engagement. And thirdly, which is very relevant, is that this strategic vision and reflecting all the time that what is the next step? What is the next challenge that we want to tackle? Not to try to tackle the largest issue or the most structural problem for the first time or for the first year. Is how little by little we are building on the success of a small step, but those building of smaller steps improves the coalition rather than the stakeholders that want to join and maintains in time.
Great, thank you very much. So we've had some really interesting insights there from Walter on how to make social accountability not only more effective, but also more sustainable. So thank you for those introductory comments, Walter, and this is really going to serve as a great resource for us to reflect on and add to with other experiences from other projects through the rest of the session. So I'm going to hand back to Andrew now to take us on to our next activity. Thanks, Andrew.
Thank you so much, Jane and Walter. And I'd like to invite people to find that reactions button and choose a little reaction to give Walter and Jane. Thank you so much. So we're coming to come to a panel session where we're going to reflect on what Walter has presented. And next slide, please. We are very excited to have 4 panelists. We have Telesfor from Community Health Leader, from Breakthrough Action. We've got Camden from Momentum Integrated Health Resilience. We've got Susan, who's coming to us from the Momentum Country and Global Leadership Project, and Sarah, who is from the USAID Office for Population and Reproductive Health in the Bureau of Global Health. In order to help us understand what perspective they are bringing, I'm going to ask each of them just to give a quick overview of the project that they're involved in and what they're focusing on, so that we can sort of understand that perspective. So Telesfor, welcome. Thank you so much for being on our panel. Tell us a little bit about your project and your focus.
Yes, thank you very much, Andrew. I'm going to share an experience that we've implemented under Breakthrough Action in 4 main West African countries, namely Burkina Faso, Cote d'Ivoire, Niger, and Togo. So Breakthrough Action is a USAID-funded global social and behavior change project. And in those 4 countries, we worked with respective ministries of health and other USAID service delivery partners to, in the process of having community-based social and behavior change, to roll out a community engagement process combining the community action cycle and the partnership defined quality methodologies to really facilitate community collective action for uptake of reproductive health and family planning services. So we therefore applied, problem solving and quality improvement at the community level lens, and naturally, working with the community health committees that the system already has in place, and other community platforms like the women groups and all that. Naturally, social accountability emerged as something that needed to be reinforced and enhanced. And along the way, eventually, we had those groups really working at various levels, like Walter was saying, really from the primary healthcare center level as unit of implementation, but working up to the district and all that to ensure that, there is some kind of accountability, that people were held on, including budgetization, ensuring that, the resources are properly allocated to serve the purpose of the gaps that they have identified.
Thanks, Alice. Well, that's a good overview of the perspective you bring us today. Camden, if I can move to you, Momentum Integrated Health Resilience, where are you focusing and some of the approaches you're taking now?
Sure, thank you. So MER's approach to social accountability is a guiding principle throughout our program, and we implement social accountability in all the countries that we work in. And this is due to the fact that conventional forms of representation and accountability often are inadequate to address the concerns of inefficiency and unresponsiveness in our fragile settings where we work, leading to decreased use, demand, and delivery of high quality services. Severe poverty, widespread social and economic exclusion render the populations often voiceless. Participation by ordinary citizens in determining policy, strategy, service delivery is very weak, and there is a need to establish a better dialogue between these duty bearers and providers and citizens for a two-way dialogue for collective action. MER's theory of change focuses on 3 elements. First, citizens will be empowered and participate through amplified voices, neutral and safe spaces for dialogue and advocacy. Duty bearers and providers will have the capacity to respond to community concerns, and effective and strategic interactions will exist between these community members and providers for collective action. If these 3 elements work well, then the theory of change proposes that there will be enhanced responsiveness among duty bearers and providers and a change in health-seeking behaviors among communities due to a mutual trust that's built between these 2 groups. Key aspects under MER's strategy for social accountability include contextualization of social accountability approaches for fragile settings, attention to risk and mitigation related to power dynamics and social and cultural norms, and prioritizing women, marginalized groups, and adolescents with a focus on gender norms and roles. Thank you.
Camden, thank you so much. It's a very systematic and thought through approach, and we'll be interested to hear your perspective a little bit later. Susan, I'm learning so many TLAs in this webinar today. So MCGL, so help us understand more from what perspective you bring to us today. Thanks, Susan.
Sure, thanks so much. And thanks to everyone for joining us today. I think probably it's very hard to think about how to condense a significant amount of work under this portfolio and how to describe what we're doing. But essentially, as Professor Flores was talking about it, I felt like, oh yes, we've ticked that box, And so we, under MCGL, are essentially working at all the levels of the health system. At the national level, we're working with a very systematized process for policy dialogue to either develop RMC, and I guess let me stop for just a moment too and just note that specifically where our targets are respectful maternity care, and when we say maternity care, what we are meaning is both the woman and the newborn. And we have focused prior to this time specifically on intrapartum care, primarily because that's where most of the egregious examples of mistreatment lie, but we are expanding our focus really to include the continuum of care. So going back to the national policy level, we have a very systematized approach to policy dialogue in both developing RMC policy and or really evaluating the existing policies and understanding why or why not they have been successful. At the facility level, we've employed a number of different approaches, and while we don't call this out necessarily as social accountability, I think it is indeed an underlying principle. We have used validated tools for facility surveys that then feed into quality improvement teams and can use the gaps that are identified with these tools as and transform them into improvement aims for quality improvement committees at or teams at the facility level. We also have a significant approach that relies both on deep community and facility engagement of identifying the manifestations and the drivers of mistreatment, and then coming together as in a co-design, co-convening process to respond to interventions and activities that these groups of key stakeholders view as being instrumental in being able to address the issue.
Oh, thanks,
So
Susan. I can hear Walter in the background going tick, tick, tick as you're speaking, and that's fantastic. So we've got three lenses from projects, and it's great we have Sarah with us from USAID giving a donor perspective. Sarah, please share with us a few points of USAID's perspective here.
Thank you so much, Andrew, and greetings to everyone. Thank you so much for joining us today. USAID Global Health is working on a broad spectrum of interventions related to social accountability, and we have an overarching approach to increase community voice while working on improving various aspects of health system. USAID missions at country level and USAID Washington through programs managed by global health offices are exploring the role of social accountability in advancing respectful care in several continents of the world. And we work on improving the quality of RMNCH service delivery and promote respectful maternity care. That is, our social accountability work is complementary to that. Yet there's a need to further understand the links between respectful care and quality of care and community voice and social accountability. USAID promotes the use of a whole of system approach in social accountability, and also, we are working with the policymakers at all levels to establish an enabling environment for social accountability across government systems and also with the communities. USAID is also prioritizing addressing the demand side and promoting social behavior change. We also have specific activities designed to promote social behavior change with a focus on women's voices and agency, male engagement, and youth empowerment. These efforts require both community education and awareness raising, as well as community engagement and the design of services that are more responsive to the community needs. USAID Global Health projects, social accountability interventions are complementary to our work to improve experience of care, respectful maternity care, and quality of care. We conduct research, generate data, and review the evidence on the effect of social accountability interventions, such as community scorecards, and also on promotion of respectful maternity care. This process will helps to identify and address barriers and drivers of family planning uptake, and increases reproductive health-related trust and accountability between facilities, providers, and communities, and as well as the clients. In turn, the learning and actions promote health outcomes based on the trust and accountability. Also, USAID works in advancing access to care. We conduct landscape assessments, mappings, and refinement of community partnerships for underserved communities. We also have activities designed with a special focus on improving access to care for women and youth in vulnerable communities. In addition, USAID, yes, we also
Could I stop you there? No. Sorry, not to cut you short, but it's such a fantastic list. And what I'd like to do is to move our panel on to a set of questions. And Sarah, I think you got full ticks from Walter. I could hear him going crazy with his ticks in terms of the range of services. And what's interesting is across donors, USAID investments are comprehensive and systematic in nature, and that's great. So the next part of our panel discussion, what we'd like to do is we've got some questions for our panelists. We're asking our panelists to take their perspective, to think about what Walter was presenting from his research, and to help us really dig through that a little bit deeper. So, Susan, my first question is for you. The MTaPS discussion paper stresses the importance of mapping the accountability ecosystem. Did you map out the accountability ecosystem? And if so, how is this used to advance SA activities?
Thanks for that question. And yes, Andrew, it's a very important question. And again, I think by definition, with the construction of the processes that we have used at the national and the subnational level, we have engaged deeply the stakeholders that are really kind of applicable to that level of the health system. So, for example, at the national level, when we've been discussing respectful maternity care policies, we have engaged, obviously, the Ministry of Health, and some countries it's been the Ministry of Women and Social Affairs, the Ministry of Education as it applies to pre-service education, the professional associations, civil society organizations, anyone who, again, would have a perspective and basically insight into how to construct a policy that can then become efficiently and effectively moved into action. At the facility and the community level, by definition, the respectful maternity care operational guidance that we developed under MCSP, the prior USAID MNH flagship program, the process is again designed to engage key stakeholders from the facility level and the community level. So the women themselves who've recently given birth in a facility, the families that have accompanied them, women's groups, community health groups, and also at the facility level, we have also really paid a significant amount of attention and engaged providers, because what we've seen time and again with the results of our formative assessment is that the providers themselves also experience significant mistreatment within the health system, both from the system itself, for lack of better words, and then sometimes with colleagues and families and clients, which is really startling, but nonetheless is an important aspect that we really need to pay attention to and address.
Yeah,
that was only accentuated with COVID-19 as well. So
yeah, lots happening there in quite a wide ecosystem. And at this point, I'd like to bring Telesphore in. But Telesphore, how were you able to assure buy-in of the communities and interests to implement the SA interventions? Was it a challenge? And any lessons from the MTaPS work that you can reflect on?
Yes, certainly. I want to start by saying that community buy-in is actually at the core of community engagement. It's part of the process in itself. In fact, in itself, it should be seen as an output even, because as the question in the chat was asked to Walter about sustainability of community engagement, I'm like, how would you sustain something that people did not commit to? So it's very important to ensure from the onset that we go through a proper community entry process, that all community stakeholders in the catchment areas are properly oriented, step by step. They know what they are getting themselves into. They know their roles and responsibilities. They know the expectation of the process and all that. They analyze their past experience in participating in such endeavors and learn from that and decide whether it is worth their time, it's worth their effort, and actually allow them to reflect and give us permission to work with them or not. Give them permission to be part of the process or not. And if they don't want to be part of the process, then we leave them alone. It's as simple as that. So in our experience, we definitely had a community entry step. I don't want to get into the weeds of that, but really taking the health facility, for example, as a first layer of orientation and consultation, and going deep into each village of the catchment areas, and pausing at some moment to reflect and see, after hearing what we've said, are you interested? And actually, if they're interested, that will be a first moment of celebration. So there are challenges, but in my experience, the challenges are more related to the health system itself than the communities, because we don't want to invest enough time to build that and we think that there are something more ahead to get into very quickly, rather than building time to get permission from the communities to do that.
Yeah, I like the point there about getting permission. And getting alongside. It's really focused. Camden, can I bring you in here? Through your social accountability interventions, what information is shared with communities, and is it actionable?
Sure. So as Telesphore mentioned, communities are sensitized, and it's extremely important to bring them in at the get-go to understand their purpose, process, and roles and intended outcomes, so that they understand the full process. Information is gathered from communities as well as providers during the exploration phases. And that's extremely important because, as I mentioned earlier, many of the populations that we work with have never had a voice. And it's been really inspirational to see people with disabilities, youth, other groups come and bring their issues to the table that they've never been able to do before. I think the interface meeting that is part of most of the social accountability approaches that we implement, where we bring the providers and the community members together, really allows community members to raise their voice in a neutral setting with those providers, which has led in our case in some countries to increased trust and reliance on the health system. We do feel it's very actionable. And we're planning on moving forward and using participatory action, monitoring and action techniques, including most significant change, to look at what are the actual changes beyond just ticking off the action items in our action plan that comes from the community members and the providers. And I have to say, just reflecting on what was said earlier by Professor Flores, adaptability is key. And in fragile settings, we have adapted several of our models and brought in gender transformative approaches, because we found in some social norms assessments, especially in South Sudan, that deeply entrenched gender norms affect the quality of services. So that's something that we had to adapt to ensure that we could make sure there was a gender lens across everything we did.
Thank you so much. And some very practical ways that you've been doing that. So thank you for sharing that. Sarah, if I could bring you in from again, bringing in a USAID perspective, Professor Flores spoke about vertical integration. What does it look like in your social accountability activities? And can you provide an example?
Yes, so our projects are working extensively across the various levels of the health system, including the national, subnational government, policymakers, CSOs, local organizations, faith-based organizations, and communities, to shape favorable policies and support the advancing of social accountability mechanisms in the local areas where we work. It's just important to mention that I did go through the MTaPS discussion paper that describes the definition for vertical integration, while we sometimes in our projects we might not exactly use the term integral integration, but we do work at the policy advocacy level, and that's what we call it in most of the work that we're doing. And that's the term that is more familiarly used, but the definition and the description of the work is exactly the same. So, and we work with CSOs and other groups to advocate for policy or programmatic changes that meet community needs. We have capacitated CSOs and other communities to utilize data, create coalitions, cultivate relationships, conduct political economy analysis, facilitate dialogue, and also we would they would use these skills to advocate for policy changes that endanger that engender good governance practices at the community and health clinic levels. I think one important example is scaling up Samasha Medical Foundation's motion trackers, a lot of capacity building efforts that are going on in many countries that we are working. We have our projects have done a collaboration with 5 Kenyan county governments to encourage CSOs, including youth champions, the media, and the public to participate in budget hearings and decision makings, which was a key step in mobilizing domestic funding for reproductive health and monitoring the budget execution. Another example is in Benin, where there was a capacity building and awareness raising sessions conducted with women and youth groups, especially with the ones that are more vulnerable to STIs or HIV/AIDS, and also our projects help them develop their work plans, which also is a great effective step towards implementation. So I'll stop here and welcome any questions.
A wealth of experience to draw upon, which is so fantastic to hear. And one of the key points that's coming out from both Sarah and Susan is that the terms from what Professor Flores shared may be different, but there is similarity there. Camden, at this stage, if I could come back to you, one of the important aspects of having models and having this sort of reflection on approaches is to deal with bottlenecks. What sort of bottlenecks have you encountered in your implementation? What approaches have you used? And does there anything in the MTaPS implementation that might be of assistance there? Thanks, Camden.
Sure. I think in our settings, one of the key bottlenecks is violence and conflict in intervention areas. And in these cases, we've had to engage with communities remotely and encourage that activities will continue once that violence will cease, so that they have faith that we will come back and continue social accountability activities. Uncertainty of intervention success, where we've had to have multiple levels of buy-in from the national to the local level, as others have mentioned. The coalition building that was talked about earlier in the MTaPS results, I think is also something that we've had to look at. High community dependency on NGOs and donors, and that sort of donor-driven mentality. What we've really focused on is tried to have the process owned and adapted by communities, so that we can manage their expectations in terms of receiving incentives and being able to participate in that social accountability work. And we've seen that through some of the action items that have come up, whether it's building a ramp for individuals with disabilities or working on how to use local community resources to fix bridges during floods. And lastly, potential tension during those interface meetings that I discussed earlier. And one thing that we've done is found localized solutions. We often call them parking lot in the United States. And what we've asked our country partners to do is, what does that look like in country? And some of those are traditional songs or storytelling to really sort of lighten the mood, to get everyone back into a neutralized setting when things get heightened, when they're discussing issues that may really cause tension between providers and communities. I think from the MTaPS paper also, in the campaigns and negotiations between providers and clients, wrapping around supply side issues, as we've seen some of those issues come up, is very important as well. Thank you.
Thank you for that. And thank you for bringing up that sort of funding sustainability action aspect, because that's something I'd actually like to ask Sarah. Sarah, can you describe the work that USAID's doing to ensure sustainability of social accountability interventions?
Thanks again, Andrew. As mentioned in my earlier responses as well, USAID Global Health projects are working on a very broad spectrum of activities, advancing social accountability, addressing both supply and demand sides of the work, and it's very crucial for the USAID to ensure sustainability of social accountability initiatives in the work that we are advancing globally. Therefore, we collaborate closely with the CSOs to leverage existing faith-based organizations with the goal of fostering sustainability among local partners and ministries of health to build upon and drive continued respectful maternity care promotion and mistreatment reduction efforts. We work with local CSO partners to develop RMC reduction efforts, and also we work with local CSO partners to develop RMC approaches that foster community accountability for RMC to allow for a more robust, holistic approach to strengthen and institutionalize quality of respectful care. Meanwhile, in order to ensure a long-term sustainability of youth-led social accountability interventions, USAID MCGL project published a landscape review of youth social accountability interventions and identified challenges related to youth participation, health system responsiveness, and an overemphasis on short-term project-based accountability compared with sustainable youth-led movement building. So we also explore promising practices that are out there on social behavior change. So I will stop here and welcome any questions. Thank you.
Yeah, thank you, Sarah. I mean, that we're all moving towards that sustainability aspect, and there's some very creative and sustainable aspects there. So let's move the conversation to broad coalitions, this aspect of the MTaPS framework that was presented. What broad coalitions have you developed or have you worked with? Was it effective? And if not, what lessons from the MTaPS paper do you think could improve effectiveness? Thank you, Telesfor. I just asked you, Telesfor, just to unmute yourself. I'm sorry.
Yep, they always trap. So yes, definitely we worked with the idea of having a movement built at the community level. We did not really create new coalition, but by design, all those countries' community health policies and strategies recognize community health groups and all that. So we work within those organizations to ensure that a movement was built for quality improvement and problem solving at the community level. And I have to say that's really challenging because it needed to be really recognized and embedded into the health system itself, so that it's not really heavily project driven, but really community led or system led, I would say. So I would say that this is really the most challenging part. And one lesson we learned that I would like to add, I think Walter touched it a little bit, it's bringing in media or community media. We tried to work with community radios, for example, to ensure that whatever is happening at the community level is amplified and socialized with the broader community to kind of build a movement around social accountability there. And certainly that's something that we need to dig in a little bit more. So not really working with the community medias for passing on messages, but working with community media to ensure that social accountability is an agenda and is part of the discussion in the community place.
Yeah, no, thank you for that. And Suzanne, this is where I'd like to bring you back in and ask you a little more about your project. Who are the key players in your social accountability program? What sort of stakeholders outside of the typical public health stakeholders did you engage? And any ideas on how you could engage your stakeholders better from the MTaPS discussion paper? Thank you, Suzanne.
Thanks, Andrew. And yeah, again, depending on which level of the health system we're working, will determine which stakeholders we're engaging with. And as we said, at the national level, when we are looking at developing policy, what we have done is pulled in, anyone who might be either responsible for implementing, interested in implementing respectful maternity care policy. And just as an example, I feel like this is a demonstration of kind of the success of engaging a broad array of stakeholders. The RMC policy language that we developed in Rwanda has now been inserted into the National Health Sector Plan strategy, which they are in the midst of revising. So again, that I think basically what I can say is that broad engagement is so key, and depending on the level of the health system, the types of stakeholders or the constitution of the stakeholder group will vary dependent on what the target, in our case, is of ameliorating mistreatment and improving respectful care for women and infants.
Great, thank you for sharing that. And across our panelists, we've had some interesting perspectives where they've been able to reflect on aspects of the MTaPS paper, but bring some practical application. I think one of the key aspects that's coming across is nomenclature, that what's mentioned in the model that Professor Flores presented is actively being done in other places, certainly some parts of that model, and that's come through. Would invite all those on the call, if you've got a particular question or a comment, please put it in the chat. We'd love to hear it. And panelists, if you have a question you'd like to ask each other, that's also very much allowed. There may have been something there to come up with. But just while we're seeing there, I'd like to, Sarah, come back to you and just ask you a final question. As you reflect on the lessons presented today and the different discussions, is there a key particular element that you'd like to see projects try? Is there a particular aspect of social accountability interventions that you'd like to see better championed? Thanks, Sarah.
Thank you so much, Andrew. That's an important question, and I think what we are particularly curious to know or learn more about is to better understand the linkages that are out there between social accountability and how it advances respectful maternity care or respectful care overall, as well as the quality improvement aspect of the work. So, what would be I would just give the example of an important tool, for example, community scorecards that are there. We know it's a powerful tool. How extensively our projects have used them, and what are some of their lessons learned, how would they basically portray or make that linkage between social accountability and respectful maternity care? I think that's an important question for us.
Yeah, thank you. It's one thing to be talking about interventions and actions, but they actually have to improve health outcomes in the end. And so thank you for reminding us of that importance. Telesphore, if I could come back to you, again, as you reflect on the discussion today and on the MTaPS paper, is there a key element that you would like to try in your project, or a particular point of emphasis that comes out?
Yes, talking about vertical integration and sustainability and all that, I think we ought to do much more on ensuring that what we do in terms of community engagement, all the processes, the facilitation that we are doing is really in the back end integrated at the operational level in terms of planning and budgeting, because we are there as project putting in human resources and financial resources and all that to facilitate those processes so that it can ensure social accountability. But how do we embed it into the system in itself so that slowly they don't necessarily need us to initiate that? Maybe external outsiders can come in to help enhance quality, but it should be really institutionalized. Yeah. So, and we have to tap also into the existing movement of decentralization with local municipalities having budget and certain competencies that the government has given to them. How do we tap into those opportunities to ensure that the local government, local municipalities are accompanying the movement, because they do also have resources?
Yeah, no, thank you, Telesphore. And it was interesting. I think this point about integration and your responses sort of sparked a question in the chat here. And just before I open up to others who may have an answer, do you have any thoughts on how best to match bottom-up SA efforts and topics with top-down policy priorities? So how do these two, as we look to do that integration, how do they intersect? I'm going to keep the hot seat to you, Telesphore, to see if you want to keep it going for a moment.
And they do intersect. We just have to implement what we have written in our policies. The health system is organized in a way that each level of the health pyramid has roles and responsibilities clearly defined. Most of the time, it's just that we do not have the resources to implement it as by policy, or we don't have the capacity to do that. Otherwise, there is all, from what I know in Asia, in Africa, all ministries of health has community health policies that allows communities to implement collective action, you know, from the primary healthcare level. We need to enforce that. And the district level and the regional level also have their role defined, not to actually do the change, but ensure that the change is happening according to the processes that there. So everyone has just to play the role by design that the system is recognizing them to play.
Thank you. Yeah, and I think Camden might want to come in here. So go ahead, Camden.
Yes, thank you. Two examples. One of the criteria for choosing the social accountability approach in each of the countries that we use is what already exists in either national policies or programs, or what has been done in the past. And so we do a broad analysis of what has been done, talking to different stakeholders. And in South Sudan, partnership defined quality was actually in the health strategic policy, just not really operationalized yet. So having it there and really being able to unpack that and operationalize it has been really useful. And then in Burkina Faso, we were quite pleased to hear that the national government wanted to hold not only a national SBC meeting to have a national strategy, but a national meeting for social accountability to choose the best method moving forward. So we're looking forward to seeing how we can work as Momentum Integrated Health Resilience with the models that we use to complement what is agreed upon among stakeholders at the national level, and then move that down into the regional and subnational levels within where we work. Over.
Great. Thank you. I mean, it's some great examples. And Suzanne, I can see you smiling and nodding furiously a little bit earlier. Is there anything else you'd like to add to this question? The meeting of the top and the bottom, and you're just on mute at the moment.
Okay, sorry. I just really agree with what Telesfor was saying, in that at the end of the day, the national level stakeholders need to support the movement of policy into practice. And then the local and district level stakeholders, excuse me, need to be able to operationalize what it is that they see as key strategies. And one thing I did want to mention in terms of respectful maternity care, and someone brought this up earlier, one of the challenges that we have seen repeatedly is that the mistreatment and sometimes violence that occurs during the continuum of care for reproductive health care is so normalized that women don't even recognize that what they are experiencing is really just denying their basic human rights to respectful care. And so I think that in and of itself is a challenge that we need to consistently pay attention to, and when working with communities, really be able to broach carefully and sensitively that aspect of people being able to say, but wait, this is a human right, and I need to be able to advocate for that. I mean, one of the things that we see over and over again, particularly in this arena, is that because there have been so many examples of mistreatment, there is underneath the surface kind of a long simmering resentment, and there's inequity, there's gender bias, there's fear of challenging the health system. So moving through these processes really needs to be handled extremely skillfully in order to achieve the kinds of results that we're really looking for.
Thank you so much for that. And Sarah, I'd like to just come in with a different sort of thinking here. Reshma has asked a question that I'd like to get your perspective of, and that is, what about the media as a non-typical stakeholder to amplify voices? It's been referred to, but not much. Do you have a perspective on that? And it might build a little bit on what Suzanne was talking about. Where do you see the role of the media here in voice amplification?
the role of the media is really important, especially the social media. If we look at it in today's context, the kind of influence and reach that they have within the communities, it's really important. And in all kind of the work in outreach or social behavior change that we are doing, reaching out to media and involving both the visual, vocal, and as well as the social media, it is part of the work, and it can be a game changer when it's used effectively. I think it's really important how we strategize our messaging to the target groups that we want to reach out to the communities, to the providers, I think it's in the discussion of respectful maternity care. I think it's really also important to have the providers side on, and given the burnout and the kind of pressure that they have been going through lately. So it's really important to engage them as well and have their voices heard too, and actually address it. It cannot be just a chronic problem that keeps raising, but there is no addressing of the issue. That will just cause a fatigue, and eventually people will just give up raising their concerns. So it's really important to tackle that and give them the tools and the opportunity and the time that they need to deliver services effectively. And also, as we are discussing today, giving the community the voice and reach to raise their concerns and their complaints and their feedback, whatever it is, and actually address that too. So that's really my take on it.
Thank you. Yeah, thank you. And last week was International Health and Care Worker Week. So thanks for bringing that message into this discussion as well, because it's something that's often overlooked. Tell us, well, if I could come to you, one of the aspects of giving that communication and knowledge, evidence, policy in local communities is the whole language question. This hasn't come up too much, but we've got a question from Mona who's asking for some advice on how we distribute knowledge, evidence, and policies to local communities in language they understand and at an education level that they understand. Just some thoughts from your experience there.
Yes, wonderful. I'm glad I'm definitely, it's not in French or in English that we are going to engaging the communities. So the people we are having as interface people, we have frontliners, we have those who are not necessarily project staff, but identifying from the health system or from other sectors like agriculture, education. We need to identify those who are what I call we can call them extension workers, but definitely the front, those who have their hands in the dust, they are the one to understand this policy language and to be able to bring it in a very simple language, but using local language. In French, there is a difference between language and the mother tongue, but you really have to engage the communities in their mother tongue. And using the language, a language that is really simple and even culturally appropriate, because depending on some communities, the use of proverbs, images, symbols, not images like photos or pictures, but speaking with images, from that in a way that it's culturally appropriate, will help the communities. It will help win their hearts and really engage them in such a way that what we are scientifically navigating through is brought down to earth for them to really understand what is an indicator, what is quality, what is a standard. All these are feasible, but definitely we need to look at the people who are the community engagers. They are really key here in terms of profile and competencies. Thank you so much, Telesfor. And I think your comment about going out of the health sector to look for some of that competence is a really valid one. I think often in health, we tend to have a little bit of an echo chamber. So thanks for that challenge. Yeah. At this point, I'd like to—
Can I comment? Oh,
yeah,
sorry.
Please, Suzanne, go ahead.
I can see that Telesfor and I are kind of thinking along the same lines, but one of the experiences that we had when we were working with respectful maternity care in Guatemala in the Western Highlands, which is primarily an indigenous population, was that we engaged sociologists to help us disseminate the information that we had acquired with a set of tools that we developed for the operational guidance. And then we also engaged a woman, for example, who is a nurse, but an indigenous person, to help us not only translate into the local language, but who could really act as a bridge between that indigenous culture and a more westernized culture. So again, you know, thinking carefully, understanding that these are sensitive issues and one needs to tread carefully and be aware of who the essential stakeholders are, I think is just absolutely imperative when you're working at a community level.
Thank you so much for that point. Professor Flores, I'd like to bring you back on if you'd like to unmute and to also put your camera back on. There's been a lot of discussion in the chat. You've heard from our panelists. Would you like to take a couple of minutes just to offer some reflections on what you've heard or some points you'd like to emphasize from the discussion? Over to you.
Yeah, thank you. First, I think it's really great, all the examples that have been presented by the panel, because that means that we are very much aligned with the principles, also with the ideas and the strategies, although using different terms, different concepts. I mean, this is fine and great for now, because we know that we are not that far away apart. However, for the short term and the midterm, if we want to learn as a collective, we will have to develop and agree a common set of terms and a common set of also of strategies, because that will allow us to identify the lessons that we are learning in different countries from different organizations and share them among ourselves. So again, I think that that's probably the most immediate step that I see from this effort, that we should build the collective set of terms and strategies that we allow us to continue our learning and then share what we are learning, all of us together.
Mm-hmm. Thank you, Walter, and that's a good segue into one of the next little action points we have as well. So just before we close, just to ask our panelists, any key message or key point that hasn't come out that you'd like to wave the flag on just now before we go to the next part of our agenda? Okay, great. I would like sorry, Camden, go ahead.
Sure. Something that I had posted in the chat, especially in fragile settings, when I was talking about mitigation strategies and really looking at risk and conflict, you know, we have to pay particular attention in making sure that we think through ahead to look at making sure that we're not having any unintended negative consequences. Because a lot underlying social and gender norms we found are so important in trying to understand how to work with the communities and the providers in a way that does reduce or eliminate those unintended negative consequences. So I wanted to just raise that as a point moving forward.
Thank you. That was something that we hadn't brought out as part of the discussion. So thank you so much. Telesfor, please go ahead. Don't forget to unmute yourself.
Yes, I wouldn't be happy with myself if I don't say what I wanted to say. You know, we've been all working, I think we've been in the place long enough to know that what we are saying, we can quickly agree. We know how to engage communities. We know how to implement social action. And we've been doing that, you know, since Alma Ata, the guidance were very clear. And the question now is like, why is it that we are not able to do that at scale? Why is it that it's not sticking, you know, with the government counterparts? And we ought to really maybe flip the problematic a little bit and look at it differently. Maybe we need to do more work with the ministries of health and with the government so that what we are doing through projects and NGOs and all that is really taken seriously as part of their agenda.
Great, great. And I think that's a great point to finish off our question time for this panel. Back everyone, as we're getting the slides up, I just want to thank you all for returning. And also, just to see how your IT skills have been developing, I want you to go down to the bottom of the screen, choose reactions, choose something that tells you how you're feeling right now. Choose a reaction that says, how are you feeling right now? I want to see if you're finding those reactions. If you ever get a chance to go on a webinar with any groups from the Philippines, they use these reactions like every couple of minutes. Welcome back to session 2. The first part of today, we had a great experience of being introduced to some work being done by MTaPS on social accountability, looking at a framework based on a large piece of work that Professor Walter Flores has done. We've had some panel discussion where we've looked at perspectives of projects on social accountability and USAID perspective as they've interacted with that model. And now what we're going to do is have 2 sections of flash presentations. The first set of 3 presentations is designed to focus on social accountability activities from a project perspective, looking at implementation, challenges, approaches, and any reflections on the MTaPS work. Each of the presentations will be 7 minutes. The first will be a recording, and then we'll have further 2 live presentations. I will give live presentations just a little verbal 2 minutes to go, just so that people are aware of the time together. And like previously, there's opportunity for questions. So we'd invite you to use the chat if you've got a comment to share, or if you've got a question to ask, and we'll go from there. Next slide, please. So we're very excited to have Kenny and the Snazi from Momentum Integrated Health Resilience Project. We've got Vivian Amaki from Youth Advocacy on Rights and Opportunities, who'll be speaking with Maggie Wanya from the Momentum Country and Global Leadership Group. And then to finish off, we have Adrienne Martin-Hilber, who will be talking to us from the Health Evaluation and Applied Research Development projects. So hang on to your seats, and there's a lot of exciting things to hear here in our flash presentations. And next slide, please. Okay, we're going to listen to this recording together.
Yourself and social accountability in South Sudan.
Okay, thank you. Good morning, good afternoon, everyone. I am Kenny Athanasius, working for Momentum Integrated Health Resilience in South Sudan. In regards to the background of social accountability in South Sudan, as all of you know, South Sudan is one of the conflict-ridden countries in the world, and this is a fragile setting. And then the kind of activities we are implementing, or the strategy we are implementing, is the community action cycle that integrates the partnership defined quality. This process was selected based on the context of the fragility of the country. The social accountability strategy that Momentum Integrated Health Resilience is using in the country ensures that we are able to use the partnership defined quality, a methodology that engages the community and also the providers in discussions, and making sure they are able to link and be able to address issues, to make sure they are able to understand the side of each one's story. For example, we talk about the community. Yes, what is it about the community that the facility providers would want to know, and also what is it about the work at the facility that the community would want also to know and understand, such that the community may not see providers from a different perspective, but with a common eye, like this is what is happening, and we may need to go to the facility to get those services, because some of the issues that affect the providers sometimes hinders communities from accessing, or hinders the community from going for services in these facilities. So the community action circle is a strategy that we are currently implementing in the country, and it uses 4 phases. But the first phase of the partnership defined quality as integrated with the community action cycle. We know it's called the building support phase, where we bring in other stakeholders, including the government, the NGOs, community-based organizations, to be able to share with them the strategy and also make sure they understand the strategy. As for the government, we make sure we have their buy-in of the strategy. So the second phase looks at the exploring quality, where we discuss with the community and making sure the community shares with us their views about what they meant by quality in terms of health service provisions. And also, we also discuss it with providers and making sure the providers also share their part of the story as to what they meant by quality health services. In the third phase, where we make sure we bridge the gap, we bring in the providers and then the community, in making sure the community and the providers discuss these issues identified during exploring the quality stage, and making sure that issues identified are either thrown or kept for further implementations. For example, the issues identified, if they are kept, what we do is that they are moved to the next stage, where a work plan is drafted to be able to counter these issues. On the fourth phase, it is a result of the third phase, where we create what we call the quality improvement teams at the community level, to be able to link with the quality improvement team at the facility level, to be able, and then they discuss and make sure they are able to have a common understanding of the happenings within a health facility, so that the same information is relayed to the community, for them not to look at the facilities with a different eye. For example, if medicines are finished, the community should be able to know, like, these medicines are finished. Otherwise, the community will start thinking the providers are selling these medicines for their own gains, leaving them without any medicines. Next. Okay. In relation to the successes of and the outcomes of partnership-defined quality, partnership-defined quality has really gathered a lot of momentum in the country, and we are able to realize some of the successes it has already gained. For example, the community realized the importance of coming together and making sure they have a joint vision towards what they wanted as a community. The second thing is that the community were able to use the ideas of the partnership defined quality to be able to come together and bring the limited resources they have to foster or to be able to get the change they want. Next. Yes, in relation to the enablers and challenges, there are a few of these challenges that I would want to share with you. One, partnership defined quality as a strategy we use in the country is able to create transparency in the country, and also it makes the community acknowledges that some of the social norms that are that are currently in the community are really diverting some of their thinking from achieving the quality health services. Next.
Penny, we have about 30 seconds left.
Okay, next. Yes, and then lastly, some of the benefits we are realizing in community engagement as a result of this, as a strategy for social accountability, is that the community, the partnership defined quality empowers the community and ensures that they are participating at all times and making sure they are part and partial of all the activities that happened in their locations, and make sure they have ownership of what is happening in the facilities or in the communities. This is the end of the presentation, and thank you for listening.
Thank you very much, Kenyi, and thank you, Camden, for your arranging of that recording. It's great to have a voice from South Sudan presenting. Encourage, if you have questions in the chat, please put them in the chat because we have representatives from the project here. And now we'd like to hand over to Maggie and Vivian. Please go ahead.
Thank you so much. Good morning, good afternoon, everyone. My name is Margaret Kwanja from Youth for Sustainable Development in Machakos, Kenya. And we are here to present our work on youth-led social accountability, both in Ghana and Kenya. And I will let Vivian, my colleague from Ghana, to introduce herself. Go ahead, Vivian.
Hello, everybody. My name is Vivian from Ghana, and I work with Youth Advocacy on Rights and Opportunities, YARO. And hello.
We can hear you clearly.
Thank you. So we're actually working on the project Youth-led Social Accountability, and with this project, we are looking at how young people are holding government officials and service providers accountable for the provision of their entitlement, which include quality, equitable and accessible health services when it comes to family planning and adolescent reproductive health services. And so the Momentum Country and Global Leadership, MCGL, form partnership with two youth-led organizations, one in Kenya, that is Youth for Sustainable Development, YSD, and also one in Ghana, Youth Advocacy on Rights and Opportunities, YARO, to implement this project. And so MCGL actually has been providing support on organizational and then technical support through the implementation of this project. Thank you.
All right, thank you, Vivian. Next slide, please. Next slide. Yes, so how do we conduct the youth-led social accountability project? We have a four-pronged model of youth-led activities. First, we raise awareness among young people on sexual reproductive rights and entitlements, with also key stakeholders, including community duty bearers. We have parents, religious leaders, opinion leaders, policymakers, and the health staff themselves, and the larger Ministry of Health directors. So we do this by having physical awareness sessions. We have radio sessions, online campaigns, drama, and debates, among others. Secondly, we conduct the community scorecard approach, where we bring adolescents and young people and duty bearers and the health staff to assess health facilities. And thirdly, we coordinate response to action plans that have been developed through the community scorecard, and we hold interface dialogue meetings and with the ministry counterparts and other stakeholders to ensure that the gaps that we found during the community scorecards are being acted upon. And lastly, we learn how youth social accountability mechanisms operate, the impact on family planning and reproductive health services for young people, as well as potential effect upon different dimensions of positive youth development by collaborating, learning, and adaptive exercise and tools. So next slide, please. Vivian, kindly go ahead.
Sorry, Vivian, you're currently muted. Vivian, just to let you know, if you could unmute yourself, that would be great. Thank you. Go ahead.
Thank you. Can you hear me now? Okay, thank you very much. So we're talking of the progress and the results we've achieved so far. I must say that both YARO and YSD have made great progress in the implementation of the Youth-led Social Accountability Project. And as you can see in the slide, both YARO and YSD have been able to train quite a number of youth volunteers on the community scorecard approach. And also, YARO and YSD are working in some selected communities. And to assess any progress from this start of project, we also have been able to organize dialogue meetings. That is for YSD and Yarrow. Also, we've conducted follow-up meetings, and Yarrow, YSD also have been able to reach quite a number of people through awareness creation. That is through drama, debate, mommy and daddy clubs, meetings. Thank you very much. Next slide.
Yes, at this juncture, we would like to present some of the learnings and reflections we've had by conducting the youth-led social accountability work. And what has worked well for us is that we found this value of youth partners in leading social accountability work, giving youth opportunity to drive change according to what young people want and need. Is something that we've seen very important. And we also build assets and skills within community and broader health systems, and youth are an asset to the whole community. So once you work towards improving services for the young people, the whole community at large benefits. And empowering youth empowers also the whole community. We've also seen tailored mentorship, capacity development, and technical assistance as a learning and reflection. There's continuous communication and support between the different partners, and so we find that turning to the needs of the partner also helps us to implement youth-led social accountability better. Also organizing networking calls with youth partners to collaborate and also to learn from each other has really worked well. Capturing learnings throughout the implementation process. So we are creating a learning journey with youth partners, monthly learning calls, learning how to conduct new types of exercises, like the most change that has earlier been talked about, net mapping, and after action reviews. Can we go ahead and talk about the challenges?
Okay. To talk about the challenges, we have encountered quite some few challenges with engaging civil society. And one of the challenges I want to talk about is power dynamics. And so at the start of the project, community leaders and some health workers, let me say Ghana Health Service, had assumptions as to how young people were going to lead this process. Because the normal thing has been like the adults advocating for the young people, but here is the case we want young people to lead, and how was that going to be possible? So it was actually necessary for us to explain to them why and how necessary it was for young people actually to lead the process, because we believe in the saying that nothing for us without us. So you can't be working for young people and not involve them. The second one I want to talk about also has to do with relationship building takes time. Actually, in Ghana here, Yarrow has got quite a good relationship with Ghana Health Service, but with this new approach of allowing young people lead this process seems like a challenge along the line, because we needed to explain more to them why we want young people to lead this process. So that actually took quite a number of time for them to buy into the idea before whole implementation started. Thank you.
Thank you so much, Vivian. So we're going to talk about the lessons from the MTaPS paper that we've been talking about here. And Yarrow and YSD have already been using several of the lessons from the MTaPS paper, as the paper was based on great research from Fox and others that was also incorporated into our theory of change and social accountability work plans. This includes utilizing several complementary tools for strategic social accountability. This activity uses community scorecard, but with awareness raising initiatives, as well as several learning tools to capture data and adjust programming as needed. We are also implementing and coordinating at different levels of governance. Our youth partners are working at the community level by bringing issues on the country and district levels. So Momentum Country Global Leadership is also working to increase visibility of the youth partners like YSD and the Yarrow work at higher levels within the Ministry of Health. And facilitating enabling conditions and building coalitions of actors beyond traditional stakeholders. One of our key focuses is enhancing the enabling environment surrounding youth's access to family planning and reproductive health through having youth-led organizations lead activities. We are engaging non-traditional actors in the social accountability processes, such as adolescents and youth, particularly those with unique needs, those youth with disabilities, sex workers, civil society organizations, religious and community leaders, among others. Thank you so much. Those are our learning and reflections. And thank you so much for this opportunity. Over to you.
Thank you so much, Maggie and Vivian. A great summary of your work. If you have questions for this project, please put them in the chat. Next slide, please. We're going to go to the third flash talk in our series. Adrienne, over to you.
Hi, everyone. Thank you very much. Can you hear me? I think you can.
Clearly.
Great. Hi. So I'm Adrienne Martin-Hilber, and I'm making a presentation on behalf of the Health Evaluation and Applied Research Development Project. We conducted a pilot study based on an assessment tool to measure the maturity and performance of national social accountability systems in health, and it was in Rwanda and Malawi where we did this. The project of testing this tool that had been developed, entitled the Accountability Development and Measurement Framework, basically looks at how accountability is developed and what happens when it's institutionalized, because we've been talking a lot about social accountability and the goal of sustainability and these things. So this project actually has its starting point looking at places where actually those social accountability mechanisms have been implemented by the government. They've been transferred over from civil society or from traditional structures to the government. And then what happens then? So that's what the basis of this is. And then based on the tool, we looked at some criteria to see how well these structures are in fact functioning as a social accountability. And the domains we looked at were structure of the social accountability system, the function, the sustainability, the effectiveness, and ultimately the transformative role it plays. So does it actually become institutionalized and create a greater accountability in the system? So the next slide, please. First, I'll talk about Rwanda. So in Rwanda, there was a recognition, particularly the post-war reconciliation period, that the government needed to demonstrate good governance through national social accountability mechanisms to improve health services. And so they initiated it at the national and central level, particularly in order to demonstrate progress against the MDGs and now the SDGs. In Rwanda, the system they decided to use was actually the traditional structures that they wanted to tap into, the traditional governance structures at the community level, and apply that to different levels of governance. So what they did is through the National Strategy for Transformation, they basically obliged these national structures to be more inclusive and present accountability. They used a volunteerism policy and the sector strategic plans to actually create this greater accountability. So they had these homegrown initiatives, as they were called, where it would be similar to community dialogues. People could raise issues. There was different kinds of mechanisms, including, for example, arbitration when there was a problem. They involved village health committees. And all of these things are embedded actually in the structure in Rwanda of not only the health system, but all social services. In doing so, they, as a strength of that, they really leveraged these local processes and incorporated them into the formal health system, which obviously lends an air of sustainability, but also government commitment to social accountability. The problem that they encountered, however, is that the follow-up in different parts of the country was not at the same level, and therefore they are struggling to maintain the same level of openness, transparency, and inclusion of the community across the country. I'll tell you in a moment how that system actually was rated based on the application of the tool. Now I'll switch to Malawi. Next slide. So in Malawi, it was a different structure. In Malawi, it was a national government quality assurance policy, which included an ombudsman in all the facilities to improve the quality of care. This program had started with CARE and Malawi, the World Bank, and other international partners, which had incorporated social accountability practices and structures into the quality assurance and community health improvement strategies to increase accountability for health for the population. They were also motivated by the MDGs and the SDGs, and in the end, took over some of these scorecard mechanisms and created a directorate of quality management, and which in fact was a government-paid ombudsman function that was then situated in all health facilities in the country. So it really was a transfer of a citizen-led, CSO-led accountability structure that then got taken up by the government. So slightly different histories, but certainly able to see how the government was committed to all of these things. So what were the strengths of the accountability system in Malawi? They operationalized complementary policies into institutionalized bodies at the national and subnational and community level to promote and facilitate community engagement, collaboration, communication, and oversight. But again, there was a lack of monitoring data, political agendas at the national level, also started to hide problems rather than resolve them. And there was just decreasing levels of consistency and follow-up services based on complaints that were coming to the ombudspersons. Next. So when we applied the tool to these two projects, we found that they got very similar scores. In Malawi, it was 69%, and in Rwanda, 71%, in terms of the development and maturity of the program. The positives across the board was that decisive government leadership, particularly focused on the MDGs and the SDGs, and the national context post-conflict in Rwanda, really helped them inspire them to create this social accountability or to take up social accountability actions that were being done. It was a bottom-up community activism in Malawi and the use of traditional mechanisms to institutionalize community voice and engagement in Rwanda. The challenges, however, was the low transparency of data. So where in Malawi, for example, when it was CSO or bank-led, there were scorecards that were presented and all of these things. When the government took it over, the sharing of the data, the information became less so, especially related to problems. There was also insufficient incentives and obligations to respond to redress. So complaints that came in weren't necessarily taken up, which then erodes trust in the system. And then there was inconsistency across the locations. Key lessons learned from this process was that managers challenged to act on complaints against providers felt sympathetic to the providers that were overburdened and poorly incentivized. So you really put the accountability in that ombudsperson or the manager, and they are stuck between wanting to improve the system, though also being affected by some of the failures of the system for the staff. So if you think about accountability, there is accountability, obviously, to the beneficiaries, the clients of the health services, but the providers themselves also have rights, and they are often found themselves in a situation where they actually don't have the means by which to improve the service, which is a long-standing problem. And then the grievance process used to inform the systems, they basically can resolve root problems, but if you don't really look at beyond the stopgap, solving the immediate problem to the root causes, it's very difficult to to actually improve quality of care or performance, governance performance.
Mm-hmm.
The last point I wanted to make is regarding the MTaPS paper. So we talked about, and this morning we've talked about the vertical integration. I'm going off script. We've talked about vertical integration and the importance of it. Walter talked about the fact that it's both political as a governance issue as well as a health sector issue. And we talked about the formalization of integration and sustainability of social accountability mechanisms. In these cases, that's exactly what you have. You have the government institutionalizing social accountability mechanisms. And I just wanted to note that one of the challenges of this is that the people that are traditionally engaged at the community level, whether they're community leaders or activists, remain engaged and they continue to participate. This kind of system, however, does not actively pursue the inclusion of the marginalized. And therefore, those voices that weren't heard in traditional or new structures, such as an ombudsperson, likely are not likely to be engaged in a more institutionalized structure. So that calls into the question the issue of trust versus fear. Yeah, and where do we build trust for the community to take ownership and create a coalition? I appreciate the issue of having the community own the accountability mechanism, but it's still difficult to see how in the longer term we can engage other people to actually sustain the pressure when the government takes up social accountability as an institutionalized force. So it's a tension there that needs additional work. Thank you very much, and thanks for including us in this process. Thank you.
You're very welcome. Thank you so much. Some very interesting information there, and the tool sounds quite a good one to have a look at later for us. So thank you very much. There's a couple of questions which have been coming through in the chat, and we're going to answer those questions in the chat rather than orally. So particularly want to ask Vivian to be having a look because there is something there for you and Maggie to address. If you could do that in the chat, that'd be great. And if there are other questions there, please have a look and see if we can do those in the chat. We're going to move along. We're in the home stretch. So those three flash presentations were helping us to understand more of what's happening in the country from those three different groups. Thank you so much. These next three flash presentations are going to help us compare and contrast of frameworks and approaches. And my clock had a little bit of a problem in the last one, but for this one, to keep us on time, I'll let our presenters know when there's 2 minutes remaining, and I'd like to hand over to Camden to start us off. Thank you so much.
Great, thank you. So what I'd like to present now is what we're calling a learning agenda for social accountability and how this came to be. So next slide, please. So why a learning agenda for social accountability? This started with the USAID high impact practices brief on social accountability to improve family planning information and services, as well as the Measuring for Social Accountability Community of Practice annual meeting held last year in December, looking at the relationship between social and behavior change and social accountability. So in my previous life, I worked with Breakthrough Research, who did a research and learning agenda to explore key questions that needed more evidence in provider behavior change and integrated social and behavior change. And in thinking through this as a co-chair of the Systems for Health Working Group under the core group, and my colleagues, both Kristen Mallory at Children International and others, we thought, well, how could we advance the learning agenda in terms of the priority questions that are coming out from the high impact practice brief, as well as the questions coming out from the mural COP. So we consulted Breakthrough Research and Laura Reichenbach, the director of Breakthrough Research, and Sanyukta Mathur, who also led this process and finalization of these two learning agendas, to understand how the methodology throughout the entire year process that brought them to the final research and learning agendas. And through that process, they developed some implementation research spotlights, just as much as the HC3 project and Breakthrough Action have developed implementation spotlights. And we're in the process of developing case studies and technical briefs related to some of the questions in these learning agendas, especially focused on fragile settings, trust, and power dynamics, which we're hearing coming out as part of some of the key areas that we need to focus on. I'm going to give the next steps. So what I'm showing here is sort of the parallel methods that we're taking in terms of consultations. And I will get into the wraparound consultations that we're looking at and next steps at the end of this presentation. Next slide. So there's 4 current learning questions, priority research and learning questions in the social accountability high impact practice brief. And 2 of them linked to the MTaPS results. The first one focusing on integration, scalability, and sustainability of social accountability processes geared to improving the quality and utilization of family planning services. Clearly, this is focused on family planning services and information, but we can also look at commodities because supply needs to meet demand, as we all know. Secondly, the second question that's highlighted in the high impact practice brief looks at how, if at all, accountability at the global, regional, national levels can be aligned with local social accountability initiatives. And I think that we've discussed that a lot today, and there is a limited amount of evidence in that area that was found in that high impact practice brief. Next slide. So the second 2 learning questions in the high impact practice brief actually might add to the MTaPS agenda. The first one being, how can social accountability approaches designed to improve family planning outcomes work in settings and be adapted in settings that have less community cohesion, have internally displaced populations, migratory populations, shocks and stresses that affect the ability to implement social accountability in its full fidelity. And then the 4th question, which was brought up by Adrienne in the previous presentation, how can we best measure increases in trust as an outcome of social accountability initiatives? Next slide. So these 2 questions came out from a series of consultations at the Mural Community of Practice, or Measuring Social Accountability Community of Practice annual meeting last November. There was a pre-meeting that we had, I had some consultations with Susan Petrick from the Health System Strengthening Accelerator Project, who focused on a 4-country consultation looking at whether or not SBC and social accountability are actually looked at one as interlinked or if they're actually siloed. So Susan joined these pre-consultations, and then we had a session at the Community of Practice to really think about what questions around SBC and social accountability may help further that learning agenda. And these were the 2 questions that came out related to power dynamics. What actually are the power dynamics that influence these 2 areas most often? And are there power dynamics from either one of these approaches that we can learn to inform the other? So the next steps in terms of the learning agenda will be to synthesize and share outputs from the SBCC Summit in Morocco with participants, begin the outreach to develop a technical advisory network, which I'm sure many of you on this meeting would like to be part of, and we will encourage that as well, especially related to some of the highlights that Sarah looked at earlier in terms of quality improvement and respectful care. We are continuing 2 additional regional consultations, one at the World Social Marketing Conference later this month, and then one at the International Maternal, Newborn, and Child Health Conference in May, both of those being held in South Africa. And then we're hoping in year 4, again, along with Children International, to look at a DC consultation, just as Breakthrough Research did, to convene the technical advisory network, the regional consultations, to really broaden this learning agenda. And as I mentioned, Momentum Integrated Health Resilience is focused on power dynamics, trust, fragility issues, and we're looking at other partners to try and answer those other questions as well through implementation, research, through academia, and donor support. So I'll end there. Thank you so much.
Perfect. Thank you so much. And what an exciting approach that you're taking there. We look forward to see the outcome of those questions as you move along. Next, we're very excited to have Heather Hancock to talk to us about applying a systems lens. And over to you. Thank you so much, Heather.
Thanks so much, Andrew. I'm really excited to be here to talk a little bit about the provider ecosystem map. And at first glance, this may not seem as a social accountability framework. And so I want to highlight a few reasons why I think this is relevant to talk about during this consultation. First of all, the learnings from the MTaPS paper really show that there is a need for an ecosystem approach. Oh, you can stay on the previous slide, sorry. And the provider ecosystem map is just one model for taking a systems approach to intervention design, implementation, and evaluation. And then secondly, providers really are key actors in the social accountability ecosystem. And so it's really important for us to better understand what influences providers, and better understanding them and their influences can then lead to more effective social accountability interventions. And the provider ecosystem, as I'll go through in a minute, highlights the actors and the factors that across the ecosystem that influence providers. And then finally, the provider ecosystem map contains several social accountability elements itself. And before we dive into the ecosystem map itself, I just want to reflect a little bit for others on why we feel an ecosystem approach is so important. Again, as emphasized in the MTaPS paper, the first is empathy. Providers are people, and they're influenced by many factors, many of which are outside of their control. And so it's really important to have empathy for them and really try to understand them. And then secondly, providers operate in really complex systems. And we know that addressing just one factor is not sufficient, as Professor Flores was mentioning earlier. And then we also really need to think more holistically about provider programming generally. We need to go beyond just one simple intervention like training or supervision, and we need to think more broadly at what might be needed across the system. Next slide. And so we developed the provider ecosystem map, and it's the result of a rigorous co-design approach. It involved a literature review, interviews with providers, an expert consultation, and several co-design sessions with service delivery and SBC partners around the world, and also global testing of this framework. And the ecosystem map itself is an interactive map, and it visually displays the complex system in which facility-based providers operate. And I should note that this was developed for family planning and reproductive health, but there are already efforts underway to adapt it to MNCH. And the ecosystem map is organized around the provider at the center, and it includes the key actors and entities that influence providers, the influence factors, component groupings, and components. And I'll go through those a little bit more in detail. In the center of the map are actors, or the individuals and groups that might influence providers themselves, and also the entities or the organizations and institutions that interact with providers across this ecosystem. And you'll see that the actors and entities are placed in different levels, and this is according to the social ecological model. And on the right-hand side here, you can see that I've put a box, if you can click, thank you, a box of some of the actors that may potentially influence providers and their behavior. Again, this would vary according to the context, and you would really want to do that mapping to understand which actors are relevant and which actors you might want to engage with or ally with, as Professor Flores said. And the actors and entities are color-coded to align with what we are calling the influence factors. So if you see in that next level of the circle, there's influence factors, and these are kind of the broad elements or groupings of elements that interact with one another and influence providers. And then each influence factor further divides into component groupings. You'll see that next level. And then those further divide into specific components. And I'll talk about those more on the next slide. And it's important to note that these influence factors and components really interact with and connect with each other. This is a system, and so we have to think about it in that way. And those interactions and connections are what we call interrelationships between those components. And of course, the degree to which those influence factors and components shape and influence provider behavior will really depend on the context, and it will require further information gathering and analysis to understand those pieces. Next slide. So as I mentioned, the map itself is interactive. And so this is, I know this is a lot on one slide, but I wanted to give you kind of a holistic view of the factors that we found that really influence provider behavior. So there are 7 categories of influence factors that we have found that affect providers within their ecosystem. The first is the individual provider themselves. The second is the personal relationships that providers have with others. The third is the client. Fourth, the community context and social norms. Fifth, the workplace environment. Sixth, the health system governance. And then finally, the country and geopolitical context. And each of these influence factors is further divided into groups of components that influence providers. And here you can see a list of all the components that are included in this ecosystem map. And there are a lot. So I'll just call out a few. So if you look at the individual provider, for example, we know that a provider's identity, how they view themselves, can really influence how they act and interact with clients and colleagues. Their own personal experiences, their stressors, their perceived role and their commitment to the profession are some that can influence that. The clients, of course, the interaction between a client and provider, those power dynamics that have already been mentioned today really play a huge role, and the kinds of experiences that clients have had previously with the health system and with providers will influence that interaction and the provider themselves. And then at the community context and social norms level, we know that sociocultural and gender norms play a huge role, which has already been mentioned several times today. The community's expectations for care and how involved they are in that system, that the community facility dynamics, and the role of community organizations themselves. And I won't go through all of these because there are a lot, but you can see that there are several factors that we were able to map in this ecosystem of that providers are part of. Next slide.
1.5 minutes remaining.
Okay. And then, as I mentioned earlier, the provider ecosystem is just that. It's a system. And that means that the factors are constantly interacting with each other. And so these influence factors can't be considered in isolation. We really need to think about how they might interact with and influence each other. And the provider ecosystem map highlights ways that components interact across the system. So in the interactive map, you could, for example, hover over one of the components and you would see some of the other components that affect or are affected by that particular component. So just as in the MTaPS paper, we found that a provider's identity can affect their behavior and the outcome of an intervention. Here you can see this example of provider identity that can affect, for example, the facility, be affected by the facility type, the gender and sociocultural norms, staff roles and expectations, attitudes of family members, a client's identity, their relationships with cultural, religious leaders. So there are a lot of factors that are interacting with each other, and we need to consider those. Next slide. And this last slide, I just want to talk a little bit about the similarities to what was learned from the MTaPS paper. And the first of those is just that it's really important for us to take that ecosystem approach. And that was highlighted very clearly in the MTaPS paper. We know that the ecosystem affects behaviors and the success of overall interventions. And then also it's really critical to understand the ecosystem in which providers and social accountability interventions operate, including the actors and factors and how they interact with each other. And interventions need to be designed according to the specific ecosystem realities. They can't just be kind of one size fits all sort of things. They need to address those root causes at multiple levels of the system. And then there were several similar influence factors like laws, norms, governance, community involvement, and client-provider interaction that are similar across the provider ecosystem and what was identified in the MTaPS paper. And then just the final point is that providers really are and should be seen as key actors in intervention success. So we really need to think about what is influencing providers, and particularly within social accountability, what influences their involvement, their support of social accountability. And the MTaPS learnings about what influences providers also really resonates what we found in the provider ecosystem. So provider perceptions of who they are and what their role is, their feelings of support, their identity, their fear of repercussions, their perceived capacity, all of those things really are important factors. And then finally, we just really do need to consider how providers interact with the other actors across the system and really take a systems view here and not just think about individual isolated actors. So thank you.
Thank you so much, Heather. A very exciting interactive model, and we look forward. I just want to play with it to have a look. And I particularly liked the way that it was, all of the particular dimensions were set out and the different factors that affect. Thank you so much. We have a third lightning talk. And so much information. I'm sure your heads are hurting at this stage, but there's such great information for us to consider. And Catherine from the Momentum Knowledge Accelerator, welcome. And we look forward to your presentation. Please go ahead.
Thank you. You can advance to the next slide. So I'm really pleased to have the opportunity to share about an MKA activity that examined the role of social accountability in enhancing respectful care across RMNCAH. To implement this activity, we conducted a rapid literature review of peer-reviewed and gray literature. We conducted key informant interviews and focus group discussions with 34 individuals working at the intersection of these two areas. And we held a 3-day convening of USAID and global stakeholders. Next slide, please. I'll now walk you through the conceptual framework that MK developed that reflects a pathway from social accountability to better respectful care. So social accountability is a process by which first community members gain access to information on rights and entitlements. The process strengthens individuals and community collective capacity to make claims. The process then facilitates interface and dialogue between community members, health providers, and decision makers about the community's desired changes in quality of care. This multifaceted and iterative process often builds on existing community engagement platforms and leads to an increase in knowledge and conscientization by community members about their rights and entitlements, state processes, and the constraints of providers. Furthermore, they feel increased confidence and capability in interacting with health providers and other individuals with power, thus increasing their capacity to make demands. Concurrently, health providers learn about and empathize with the experiences of community members when seeking health services. Providers also learn what skills, tools, and support they require to provide quality health services, and they feel pressure to provide higher quality care to community members. Simultaneously, social accountability interventions often engage with non-health sector actors, such as traditional leaders and journalists, who interface with both community members and health providers. Click, please. This leads to mutual empowerment and a shared commitment among all parties to address power dynamics and the gaps in respectful care standards. Community members are then motivated from having participated in this process, and they strengthen and harmonize their voice to continue to take part in collective action to demand respectful care. These demands may include participating in the budgeting of subnational and health facility resource allocation and community monitoring of provider behaviors related to respectful care. Concurrently, the empowerment and commitment experienced by health providers and decision makers leads them to be more responsive to community members' requests and to provide teeth to integrating respectful care into services. They may do this through allocating larger portions of subnational resources to RMNCAH services or instituting social rewards and sanctions for health providers based on their behaviors related to respectful care. Click, please. Over time, this leads to the provision of greater respectful care in RMNCAH. And I want to note that context underlies every aspect of this conceptual framework and directly and indirectly shapes the processes and outcomes. Next slide, please. I'll now share several similarities with the action steps in the MTaPS paper. The MTaPS paper highlights the importance of mapping and analyzing the accountability ecosystem before designing social accountability interventions. In our conceptual framework, we refer to the accountability ecosystem as context. given that context can enhance or entirely stymie social accountability, we agree that it is critical for it to be understood and taken into account when designing a social accountability effort. The MTaPS paper recommends that the problem areas, capacities, gaps, and bottlenecks be diagnosed, and that the capacity of service users be reinforced. The first two steps in our conceptual framework directly address this. Indeed, the first step is for information on rights and entitlements to either be shared with community members or for community members to be supported to gather this information themselves. And the second step is for the intervention to strengthen individuals' and community collective capacity to make claims based on the information shared or gathered. Third, the MTaPS paper recommends that activities engage and form coalitions with a broad set of stakeholders beyond policymakers, such as journalists and health activists. In our conceptual framework, non-health actors, such as journalists, can play an important role by helping to amplify messages of community members, acting as interlocutors between the negotiating parties, and helping to identify the pathways of collective action that are the most effective at leveraging responses from the state. Next slide, please.
1 minute remaining.
I'll conclude this quick presentation by describing differences with the MTaPS paper. So an obvious difference is in the outcome of interest, respectful care versus access to quality medical supplies. Given that access to medical products is directly affected by procurement and other policies that are set and implemented at the national level, the MTaPS paper recommends designing and implementing vertically integrated social accountability interventions. While system-wide issues can and do impact respectful care, our conceptual framework represents a local level social accountability intervention leading to better respectful care. We decided to do a local level focus for several reasons. First, respectful care can and should be assessed and monitored, at least in part, by communities themselves. Second, respectful care is an area where healthcare workers and decision makers have discretion and are able to act on the information and preferences that have been expressed. For example, many elements of respectful care, such as polite treatment, respect for privacy, the provision of information, and compliance with consent processes are within the control of local health providers, and therefore providers have an element of accountability for their delivery. And I'll end by noting that the MTaPS paper recommends that social accountability efforts be designed and implemented with multiple tactics, given that our conceptual framework really represents a higher order generic pathway from social accountability to respectful care. It does not go into tactics. And I'll end there. Thank you.
Thank you so much, Catherine. And to Catherine, Heather, and Camden, we would like to thank you for your preparation. There's some really thoughtful and deep material there for us to go back to. So please join with me in thanking our three presenters by giving them an emoji. We have not got time for questions apart from questions in the chat today. So we would invite you to please put your reflection or your question to the presenters in the chat, and then we would just invite Camden, Heather, and Catherine just to watch out in the chat and to answer those questions. Just to note at this point that the chat will be exported and will be given to you all as an attachment as we pull our material together for you for next week. As we move towards a close, and we've been on an exciting journey, I would like to hand over to Nefra, who's going to share with us some reflections that she's been considering as we've been going through this time together. Nefra, thank you so much for joining us, and the floor is yours.
Thank you so much, Andrew. And my goodness, what a rich few hours we have had together, and what an ambitious task I have to attempt to synthesize the rich learning that's been shared over our time together. I'll start with maybe a few reflections. First, I've greatly appreciated the diversity of perspectives that have been shared from numerous countries, both in the chat and during our presentations, from DRC to Ghana, Jordan to Kenya, Malawi to Tanzania, South Sudan to Uganda, and Australia to the US. It's interesting too, because the idea for this exchange began over a couple of years ago with USAID commissioning MTaPS to conduct a literature review on engaging civil society through social accountability to improve access to essential MNCH medicines. But as we've seen both from the discussion paper and from the exchanges today, the learnings from that literature review are really transferable beyond considerations around access to and utilization of essential MNCH medicines to not only MNCH, but also other technical areas in the health sector more broadly. Social accountability for USAID is also a critical driver of localization, which is a core commitment of the agency. And localization for us is a set of internal reforms, actions, and behaviors that USAID is undertaking to ensure that our work puts local actors in the lead, strengthens local systems, and is responsive to local communities. Social accountability is also a driver for improving equity and building health resilience at the individual, household, community, facility, and systems levels so that no one is left behind. While this wasn't explicitly addressed in all of the conversations, what was clear in all of the contributions is that a core commitment of social accountability is also improving coverage, quality, and equity. And why does all of this matter? Well, of course, we are in many USAID partner countries off track towards meeting SDG targets for reducing maternal, newborn, and child mortality. So when it comes to strengthening social accountability, both barriers and solutions that can accelerate reductions in preventable deaths are contextual, they are relational, they are systems mediated, they are technical, and they are political. There are a number of themes that I've heard throughout the course of the past few hours, themes that were first introduced by Professor Walter Flores. First, just one tool or lever generally isn't sufficient when it comes to strengthening social accountability. We need multiple coordinated tactics. Just providing information is not sufficient for citizens to act, no matter who you are. Social accountability outcomes and processes, including in terms of increasing stakeholder empowerment, can take years. And social accountability interventions involve highly contextualized processes that need to be iterated, including because they proceed along complex, nonlinear pathways to achieving health outcomes. We also learned about the importance of vertical integration of social accountability. So at different levels of governance, local, municipal, provincial, regional, national, and horizontal. And we heard in the chat about the concept of sandwich strategies, that is forces and advocacy from the bottom and from the top to kind of sandwich efforts in the middle, and including by applying approaches from other sectors like education and agriculture. We know that bottlenecks to social accountability come not only from problems around lack of provider or managerial capacity, but also lack of prioritization or trust. And we also heard from many contributors today that when it comes to successful social accountability approaches, we need to ensure that we're engaging not just civil society in general, but especially grassroots organizations in particular as facilitators of spaces for dialogue. We need to build the capacities of those actors that need it the most. We need to be mindful of knowledge translation needs among different audiences, including so that we consider do no harm considerations when we roll out those communications approaches. And we also learned about the importance of mapping the accountability ecosystem and asking ourselves questions like, who are the actors involved? What are their interests and incentives in acting on the perceived problem that social accountability interventions aim to address? How do those actors interact? Who are those in positions of formal or informal authority? What are the power dynamics of their interactions? What are the conflict sensitivity, again, and other do no harm considerations that we need to map as well? One of the interesting points of exchange I found today was also around the need to better understand links between respectful maternity and other forms of care, quality improvement processes, and social accountability approaches and processes. And as we were reminded from country experiences like South Sudan and Rwanda, we need to remember that experience of care and quality standards for care aren't necessarily the same thing. Also, providers themselves often face significant mistreatment, sometimes among their own families, colleagues, and clients. That in turn reminded me of a recent experience that I was fortunate to have through participating in the Community Health Worker Symposium in Liberia. That symposium culminated in a number of country and global commitments, among which was the Monrovia Call to Action. And in that call to action, there was a statement that noted that over half of community health workers in low and middle income countries are unpaid. Community health workers are out of stock of key commodities a third of the time. Many receive inconsistent supervision, and continuous medical education is rarely available. And in that sense, the failure to treat community health workers like professionals limits their ability to perform like professionals. So again, this is a reminder that providers themselves need to be empowered to voice and hold others accountable for their needs and demands. So where do we go from here? Well, this is just the start of what we hope will be many more discussions to come. Materials and recordings from today's exchanges will be shared within the next few days, but we also hope that you will all continue the discussion by reaching out to each other, whether by email or through future learning exchange opportunities, including through the Momentum Meal Working Group for those within the Momentum Award family. More to come, I'm sure, but perhaps I'll leave it there for now for the sake of time. Thanks, Andrew.
Nefris, I want to give you a big shout out. That was a fantastic synthesis of the last 3 hours of activity, and I'm so glad we recorded it. And it's been a joyful time together, a time brought to you by MTaPS with the Momentum Knowledge Accelerator. We set out today on a journey together to really look at social accountability, but how we leverage best practices in that environment for RMNCAH service delivery. And as Nefra very adequately explained, we've been able to achieve much more than that. In the chat just now, we're going to redrop in the link to the resources page. This is a point of action for you. We've come together as a community to share from MTaPS perspective and a whole range of other projects from the Momentum Suite, as well as from Breakthrough Action and HERD. And I'm sure a lot of you have resources that you'd like to share. And that link, which will be dropped in the chat, will take you to a wiki page or a document where you can put the resources that you've got. Please take the time to do that, and we will attach that. We will also be exporting the chat, so you'll have that richness as well as the recording. And we're also going to drop in the chat just now our evaluation again. We would like you to take the time to fill in our evaluation for a couple of reasons. One, it gives us feedback on the structure and how we did today, so that we can do better next time. But probably more importantly for this community, there is a couple of opportunities in that evaluation where you can say what you would like to see next. In preparing this, there was a great energy for doing more collaborative discussions and learning more from each other. And in some ways today, I could sense some of the frustration that we didn't go deep enough. And that was the design of the day, was a taster, was to reflect on the MTaPS work, but to be exposed to a lot of other social accountability activity and to go away with action in our minds. The action we want you to think about is how you can apply aspects of the material that's been presented today to improve your project work or to improve the design of future work that you're going to be involved in. and we would like to encourage you in that regard.